In the past, 10, 15, 20 years ago, everything would go. They couldn't see. They didn't have cameras. So they would just, take out everything that they could. This is actually a patient I had that had an old surgery. So you see the difference. I hope you can see the difference.
Oh, the turbinate's gone.
There's nothing there. And her septum, look,
Wow.
she's supposed to have a septum here.
Oh, wow.
Everything's gone.
That's barbaric.
Yeah. So it's different. It's different now. So there's 8 spaces in your head. We didn't think they did anything. We thought maybe voice or singing. But all this surface area is really important because you not only feel the air going through, but you absorb the air through your sinuses.
Mm-hmm. Oh, you absorb air into your sinuses almost like lungs?
Yes. The lining converts it, changes it into nitric oxide, and you bring it into your body. So the air goes through here. You feel it the whole way. That's what makes you feel like you're getting a nice breath is these nerves. So if anything is not working right, this whole pathway, you'll feel blocked. Some people can actually be closed in the back, and that's called choanal atresia. People can have this on one side, and they just think they can't breathe through that side. And I mean, this patient can't get a minimally invasive sinus surgery, but there's a lot of work that would go into a good polyp surgery because the problem is polyps will reform on surface area. So if you don't do a clean job, they'll come right back. And before they get to see me, they're using these. They're using these sprays. And this is terrible because they're so addictive. You'll spray this in your nose. You'll feel like you can breathe great. I had one 17-year-old guy that was doing it every 20 minutes. He was so miserable. I have some patients that cry in my office when I tell them they have to get rid of this, or there's nothing I can do to help them because I can't make their turbinate hypertrophy go away if they're taking these. Because I think a big part of this is, the thumb sucking, but the pacifiers and improper nipples creating that pressure on the palate when it's so malleable is part of how we all got here. We can measure how the baby's doing before and after the tongue tie, and it's so much more efficient. I mean, these are babies that stayed breastfeeding for hours and got next to nothing. And then after tongue tie, they can feed in 15 minutes because it's actually a complicated movement that the baby makes with the tongue and the palate and the cheeks to get all the glands cleared out. If the tongue can't move fully up and down, it can't do it. I hear pediatricians all the time. They're like, it's not a problem. We're not going to fix the tongue tie. But then there's studies like this. If it helps the mom and the baby be successful, why wouldn't you?
Yeah, you're actually the first ENT that I've ever had on my channel. So
I'm so excited.
it's really important because obviously ENTs play a huge role in this stuff.
Yeah.
And if you can't breathe through your nose, you're SOL.
Right. Yeah. And we just had our academy meeting. Every year we have a meeting. And I was excited that maybe everybody would be talking about palate expansion, and nobody's talking about it. So I think what you're doing is really important. And I'm really grateful for you because I actually found Yousefian through you.
Oh, really?
For myself. Yeah.
Oh, no kidding.
So thank you for that because he's changing my life. I have, getting ready for Dame and Dane.
Are you getting ready for them or are they in?
My gap's not big enough, so I had to postpone, but getting there. Yeah.
So tell me a little bit about that. So is he creating space orthodontically to be able to put the appliances in?
Yeah. It could be because I'm going to have upper and lower.
Right.
So you can't tell because I have Invisalign in, but working on a big gap, but my teeth went this way instead of this way. So the roots are still touching. So we had to postpone.
Okay, yeah, teeth have a mind of their own, don't they?
Yep.
Yeah,
plans.
I know everyone is so preoccupied with bone structure, but when it comes to the brass tacks of like orthodontic therapy, the teeth always end up being the slowest part, the most frustrating part, and teeth suck.
Yeah, it's unpredictable. And I had to do gum grafting. It was a whole big deal, but
shit.
Yeah.
Yeah, I just did some gum grafting myself. I don't know if you saw the video of that, my SFOT vlog video.
You just did that? No, I have to watch it.
About a month ago, I had a gum graft. Actually, it's been 40 days now. Yeah, they took big slices the size of like the ginger that you put on sushi. It looked like that from the pterygo maxillary area behind my upper last molars.
That's painful.
And then they put it right there. But it's taken really well though.
Yeah,
right,
it looks
right
good.
Here.
Yeah. I had almost all my teeth from the palate.
Wow.
All my teeth grafted just to enable movement without recession. So yeah.
Yeah, I'm a big fan of people doing things like SFOT and bone grafting and gum grafting in general to sort of pave the way for tooth movement.
Yeah. Yeah.
It
And
makes
it's
it.
good that you're talking about that because you know what happens if your teeth get loose and yeah, scary.
I do know. I do know all about that for
Yeah.
sure.
Yeah.
So, well, I let my Discord know that I was having you on. Discord, you probably don't know what that is. It's kind of like a 25-year-old or less thing.
Oh, okay.
But
I don't know what that is.
you don't know what Discord is.
No.
No. And they're very excited that you're here. They fed me a lot of questions
Oh,
to
good.
ask you
Okay.
about. And I'll dive into those. But before I do, I just want to go a little bit deeper into some things you've already said. So, in your own case, what's going on with you, if you don't mind sharing? Why are you motivated to have the main and dame done by Dr. Yousefian?
Yeah. Yeah. Mine started as TMJ. And I
Okay.
think, I was clenching and grinding all through med school and residency. And then I started trying to take care of myself after all of that was done. And I realized I have almost complete reabsorption on one side. And the other side is actively, that's the other reason we're going slow, is because one side is actively inflamed. So we're trying to preserve as much as we can, but I have asymmetry and all my problems. Like, I mean, you talk about the sleep apnea, the upper airway resistance syndrome, which we know about in ENT, but we don't always put all the pieces together that they're all related.
Yeah.
The nasal breathing, the TMJ, the snoring, poor sleep, I have all of it. So
Yeah. Yeah.
once I couldn't, when I moved to this area, I couldn't find an airway orthodontist. And
Hmm.
it's a big area. No one was doing it.
Yeah.
So then I found you and I found Yousefian, and it's a big
So,
process.
so let me ask you a question that came from one of the leaders of my Discord server. His name is Shuikai. That's his screen name. He wants to know, why is it that otolaryngologists, ENTs in general, misdiagnose or
Mhm.
fail to diagnose undersized nasal passages? What is going on with the zeitgeist or the
Mhm.
current paradigm within the ENT world that the answer really is right under your nose, and
Mhm.
they're the ear, nose, and throat people, but
Yeah.
they miss it so
Why do we not
often.
know? Yeah, no one's talking about it. That's the thing is I went to my meeting, I was all excited, let's talk about palate expansion, but we in medicine, we're so specialized, which is great because we're really good at what we do, but we don't always collaborate, which is why I think this is so important. What you're talking about is we end at the teeth. We don't even think about the palate and the teeth. And in ENT, just nobody's talking about it. I think a lot of orthodontists are good sending us patients. They're good at looking for things because they scan and they find things. And so they'll ask us, but we don't go the other way. We historically just have not, it's not part of our training. It's not part of our thought process to think, even though we're part of ENT, the mouth is in our domain, we don't do teeth. So
Hmm.
I think it just never occurs to us that that is something that's important. And in addition to that, there aren't that many airway orthodontists still there, or
No.
surgeons that are talking about this or that are collaborating with us. So we kind of have to go out of our comfort zone as ENTs to find that information. And I
Right.
think it's just not on the radar.
Right, right. And even if it were on the radar, as you said, where do you send a patient to and
Hmm.
reliably get a good result from the orthodontist without getting a
Hmm.
screw up and the patient coming back to you saying, hey, what the hell did you send me to
Why?
that butcher for?
Because then the TMJ is worse. Because we do have people that are doing Vivos, you know, but I think most of us now want surgery. We want someone who thinks of the TMJ and thinks of the airway and thinks of the nose and wants to work together with us. And
Do you
those are
ever,
hard to find.
for sure, and Vivos is way more common because you have general dentists doing it. You don't really
Mhm.
need to be an orthodontist
Right.
to do it like you get with the MARPI devices, MSE, custom
Mhm.
MARPI, Ease. Only orthodontists or above do that. But
Mhm.
while we're on the subject of the Vivos, do you ever see nasal airway improvement with Vivos?
No, I
You
mean,
don't.
well, actually,
Mm.
maybe if you tip the teeth enough and you get the tongue out of the airway a little bit, then you could get some improvement, but at what cost? You're causing gum recession, you're tilting the teeth, you got to bring the teeth back into bone to do anything substantial.
Yeah.
So, I mean, no, and there's really not a way to quantify that. That's the other hard part is ENTs. We kind of look in there and use our best judgment to say, how can we help this patient when they don't have access to anything else? So I did a little presentation because I did want to talk a little bit about other things than that can cause nasal obstruction that I think we all need to be. It just needs to be on our radar because so many people need palate expansion, and I think that's great, but we might miss something else important.
Okay,
If
do you want
we're
to
only doing that.
launch right into that?
Yeah.
Yep,
Okay.
here we
So
are.
that's who I am. I practice in the
Hey,
left.
there's you.
So, I mean, I have a whole presentation. You can stop me if it's too much, but I just did a little bit about a lot of my practice is focused on keeping kids breathing through their nose so we don't end up with problems later. So it's a lot about prevention for this reason, for this picture here. Can you see my cursor?
I can, and this guy looks very familiar. He
Yeah.
bounces around the jaw hacking world quite a bit.
Oh, this, this picture.
Yeah.
Yeah. So, I mean, a lot of it is if we can keep
It's
them
Chad
breathing.
and that's Chad and Jeffrey, by the way.
Oh,
Chad is on the top, and that's Jeffrey down bottom.
Chad looks great. Jeffrey could have been prevented, maybe. So just a little plug, if we can keep them in early age. But I think most of your viewers are already fused, so then we need to talk about how do we keep them breathing and why it's important. So I just wrote a little bit about, I think most ENTs do realize it's important, but they probably don't realize the full extent of TMJ health, sleep apnea, just from mouth breathing. And then nitric oxide, there's a lot of great research coming out now about what nitric oxide does. And the main place it's made is in the sinuses. The sinuses absorb it into your body, create it, and store it for you. So it does, tons of things. My husband's a urologist, and it's important in his world, nitric oxide. So anti-anxiety.
Why is nitric oxide important in urology?
Nitric oxide, they give Viagra is basically helps you create nitric oxide. It's important for erections.
Right. So what does it do? It stiffens blood vessels, or it stiffens soft tissue?
It vasodilates, so it helps with the blood flow, because that's all an erection is blood flow,
right,
in the right direction. And
right.
if you don't have enough nitric oxide, you can't make that happen. Mm-hmm. So the list goes on and on. We could talk about a million things why nitric oxide is important, and we have all these workarounds in medicine. But really, the best thing to do would be to create a healthy environment for you to make your own nitric oxide. And that's what nasal breathing does.
Right. Doctor, while we're between slides, let me just ask you this. Do you have a way of explaining nasal ENT sinus anatomy that's accessible to lay people? Because I think probably a lot of viewers, they know that there's all these little caverns and tubes, and it's all very, complicated. Mm-hmm. Is there a way we can just give people a lay of the land before we dive into this?
Yeah, so that's what my next couple slides, I think, hopefully.
Sure.
We'll see. It's a lot of CAT scans, but...
That's fine.
Okay.
Just remember, you're talking to fourth graders or to golden retrievers.
Okay.
Please step back and give perspective on some of the anatomy we're seeing, because I personally find it very confusing.
Okay. Yeah, it is confusing. It's confusing to everyone, even primary doctors, which is why a lot of this stuff gets missed, because no one can see in there. They don't know what it's supposed to look like. Mm-hmm. But this, I started with a little picture of a normal, healthy CAT scan. So this is a patient, and this is how I explain it to patients when they're in my office. This is you, looking at me. This is your right side. This is your left side. What you want to see in a CAT scan is bright white bone going straight to black air. So all of these little nooks and crannies in here, this is the septum. This is a nice straight septum. And these areas are important because what we want in a healthy nose is not just a wide open hallway. We want healthy surface area. You want, all of these structures in here are really important because that's where the air goes here all the way back to the back of your nose, but then it also hangs out here in the sinus.
What's the point of the sinuses? Why do we have these little side rooms in the middle of our face where the air kind of departs from the main pathways and goes into these big cavernous spaces?
We only found out recently what they do, and we think it's nitric oxide. All of this has lining. And there's 8. There's these 2. There's forehead sinuses. They're not shown on this scan, but there's 2 in between your eyes, and there's 2 straight in the middle of your head, the sphenoid sinuses. So there's 8 spaces in your head that are just empty space. And we didn't think they did anything. We thought maybe voice or singing. But now we know that the air goes in, the lining creates nitric oxide, and then it gets released slowly through this little tunnel. But all this surface area is really important because you not only feel the air going through, but you absorb the air through your sinuses.
Mm-hmm. Oh, you absorb. I'm sorry. You absorb air into your sinuses, almost like lungs.
Yes. Yeah. The lining converts it, changes it into nitric oxide, and you bring it into your body. And that's where most of your nitric oxide is made, is in these spaces.
So you're not bringing in oxygen into your sinuses, but the air is being converted into nitric oxide, and then the nitric oxide is absorbed via epithelial cells or whatever they're called. The sort of like when you put tobacco in your lip, the drugs can go in through the skin in your lip. It's sort of the same idea, but with nitric oxide.
You're breathing in oxygen into your lungs, and you're breathing in oxygen into your sinuses, but mostly you're converting it into the nitric oxide. And that's the value of it.
Okay.
Is why you don't just want a big open space. You want functional space. You want intact mucosa that's ciliated. Because the other thing it does is I think we all know it cleans and purifies and humidifies the air that we're breathing in. So all of this is very functional, but it's also ciliated. It has little hair cells that sweep the mucus out, and the allergens and the dirt. It kind of directs it out this way and gets rid of it.
Mm-hmm.
So it's cleaning, but it's also creating important chemicals.
Right. And of course, when those sinuses get when they're infected and you have sinusitis, the whole thing just goes to shit.
Right. Yeah. I have a slide about that too. Yeah.
Okay, cool.
But basically it has to, this whole way through. So this is the front of your nose. You want air to go up into all that surface area. This is your ethmoid sinuses up here. This is your frontal and your sphenoid. They're just spaces. They're just holes. But this is not just space. This is all lining. So the air goes through here. You feel it the whole way. That's what makes you feel like you're getting a nice breath, is these nerves. And then it goes all the way back down, into what we call the nasopharynx, which is the back of the nose, into your lungs. Mm-hmm. So if anything is not working right, this whole pathway, you'll feel blocked. Mm-hmm. Mm-hmm. And here's another slide that shows that. So it's this hallway, but then it's also rooms off of the hallway is how you can think of the nose. I
really like this image. It's a great visual for nasal anatomy.
Yeah, this is a good one because that's what you want. You don't want it to just be, open. You want it to be as smart as it was designed to be.
Right.
So I have a couple scary slides, but I think it's important just to be aware. These are my patients coming up. So these aren't just, theoretical things that can happen in your sinuses. But I think this is why it's important to have a good ENT on the team of the orthodontist and the oral surgeon, just because we need somebody to check these sometimes. Sure. This was a guy that came in that had a sinus lymphoma. So instead of, this right side actually looks pretty healthy. He's got black air. He's, you can see some airflow, even though he didn't feel like he could breathe on either side. Just massive tumor on the left side.
That's bizarre. Really, why is it a lymphoma? Is there lymph cells in the nose?
Mm-hmm. Yeah, they're everywhere in the body. So you could really get a lymphoma anywhere.
Right. Not just here where people know that there's lymph nodes that can happen in the sinuses too.
Yeah. This was the initial, he had other lymph nodes, but they weren't nearly as obvious as this initial. It was a mass. I mean, this probably looks like nothing to you, but this is a giant mass. So he had no other room. And luckily, I mean, these things are tricky because even primary care, it's hard for them to really look in the nose and see what's going on. So you really need somebody to catch these things.
For sure.
This one was a melanoma.
In the nose?
Inside the sinus. It looked just like, she waited a while, but she was younger. You would not think she would have something this terrible happen to her because it just looked like a polyp. It didn't look like anything scary, but inside, it was kind of everywhere.
How'd she turn out?
She had to get a huge surgery, massive surgery, because melanoma, I mean, you have to get clear margins, big
I
margins.
know, I know.
Yeah.
My mother had
So,
melanoma.
oh, I'm
Yeah,
sorry.
she's fine. They
She
got
is.
it. They got the margins, but I also had a friend who died from metastatic melanoma that ended up in his brain.
Yeah. Yeah.
It's a
So
horrible disease.
she's doing okay. But
Good.
there's the treatment and then there's the repercussions from the treatment and it's rough. It's not fun.
Well, we wish her the best.
Yeah, thank you. You know, these are life-threatening, but not everything is life-threatening. I see a lot of polyps. Um, and these also get missed a lot. And you can see, Ron, I put this slide because he also probably needs palate expansion. He's got a pretty narrow palate.
Don't we all?
But all the palate expansion in the world is not going to make him breathe through his nose. There's no black in these sinuses. He's filled. These are my endoscopic pictures from surgery. This side's mostly filled. This side's completely filled. And this is tissue. This isn't like snot. It's like having a bunch of grapes in your sinuses.
What
You
causes
can't,
those polyps to form?
yeah. Sometimes it's genetics. Cystic fibrosis can do it. A lot of times, I think the majority of times it's allergies. Stuff you're breathing in that your body does not like can grow polyps. Allergic
Right.
fungal sinusitis. Sometimes we don't know. Sometimes I test patients and they're allergy negative and we don't know why they have it. But these are some of my happiest patients because then they can breathe immediately. But he also has a deviated septum. He also has a narrow palate. He needs, I think, his polyps taken out first, and then he might need some other things also.
Yeah.
But
Yeah.
this is an important one, I think, to be aware of, that this exists, because a lot of people don't even know. And it can really do some damage inside. It can erode through bone and push things around.
Right. So just a thought about why this would be really important to my audience. There's this sort of impression that you can fix all nasal problems by expanding your maxilla and making the underlying bone bigger, making the room bigger without removing the furniture, so to speak. But I think maybe what a patient like this shows is that if the room has been too small for too long, then you can get all of this crap that builds up in there. Potentially, we don't really know what the cause of the polyps is, but maybe it is because it's just so dirty and underused in there, almost like rust forming in a machine that's been sitting in your yard for too long.
Maybe.
And
Yeah.
so sometimes you got to just go in and clean things out and get a blank slate of the soft tissue.
But not clean, like you say, removing the furniture. I think it's really important to preserve the normal anatomy. So here you can see a normal turbinate. Now, even in the last 10, 20 years, we've had such huge advancements in sinus surgery. In the past, 10, 15, 20 years ago, everything would go. They couldn't see. They didn't have cameras. So they would just, take out everything that they could. But now we can really preserve normal anatomy. And I think that's important. You take out what's not supposed to be there, but you leave what's supposed to be there so it can function.
What would they do? Would they just go in with what kind of tool and then just start removing chunks?
I don't even like to think about it. A headlight. Back in the day, they would just use a headlight and start taking things out. And then we evolved and we started realizing, oh no, that's a terrible idea. And then technology evolved and we have all these really great tools where we can do image guidance. I use CAT scans in all my surgeries so I can see exactly what I'm preserving and what I'm not.
Wow.
But it's like this, basically endoscopic. But they used to do it with just a headlight.
With a headlight and then with some sort of, was it a scalpel and then tweezers to remove the chunks of meat, or what was it?
Special tools, still surgical tools that, you put in your hand and you can grab things.
Grab and rip.
And suction. Yeah, grab and rip.
Damn.
So I think that's another important point, is if you meet someone that's had a sinus surgery 20, 30 years ago, you can safely assume that it's not the same surgery that you would get today if you went to a board certified ENT.
Sure. And are we going to talk about the details of what is a truly minimally invasive sinus surgery at some point?
Yeah, we can.
Okay. That's one of the big questions that my audience wants an answer for.
Okay. Yeah. Well, that's a hard That's a hard question to answer because it really depends on the patient. I mean, this patient can't get a minimally invasive sinus surgery. I guess it's endoscopic, so it's no incisions on the outside, but there's a lot of work that would go into a good polyp surgery, because the problem is polyps will reform on surface area. So if you don't do a clean job, they'll come right back.
Wow.
So, I mean, this guy can't have minimally invasive, but he can have endoscopic sinus surgery. Someone else, well, let me make a couple other points, and then we'll get to the turbinates, because it's probably a turbinate question.
Yeah, it is. It is actually.
And I have a lot of things to say about that. Hopefully we'll answer questions.
Great.
I just wanted to point out, there are other things. This picture that I showed, anything from the front to the back, if you're closed here or here or here, you're not going to get airflow. So some people can actually be closed in the back, and that's called choanal atresia. And usually it's something that happens as a baby, but it can be missed. And, people can have this on one side and just not know. They just think they can't breathe through that side. And this is the hole in the back that's supposed to be open. So that's another. And then you mentioned chronic sinusitis. Really, you have to have openings here. You can be so inflamed that there's no opening. This is an opening I made during surgery, and all this pus, all this stuff came out, but it was just trapped in there, and that makes it almost impossible to breathe through your nose until that's cleared out.
Does that come out as mucus for like a sinusitis patient, that pussy stuff?
Well, this patient was totally blocked, so they weren't even able to drain it out. They just felt pressure, pain, discomfort in their face, cough. So sometimes it can be cough.
They lost weight after this surgery?
Probably. I can imagine.
At least a few ounces.
At least, yeah. And polyps. But yes, sometimes people do drain. And that's okay. If it's an acute sinus infection, you take an antibiotic, you feel better, you don't need sinus surgery. We really only do sinus surgery if this is scarred shut and you can't drain, your sinuses aren't functional, or it lasts months and months and months and it's not getting better. That's where things come in.
Just to be clear about the anatomy, so the sinuses are these little rooms that come off of the road that are the normal nasal passages, and the door to the room can be blocked shut, and then the sinus essentially is just this closed door where bad things happen inside if there's not two-way flow.
Exactly. Yeah, because the cells are trying to push all this mucus out, but if the door is closed, you're going to be uncomfortable. You're going to hurt. You'll have pressure in your face. Bad things can happen.
And you're not getting any nitrous oxide.
Exactly. Yeah, you're not getting air. They're supposed to have air in them. And instead, people can have pus in them for years.
Nasty.
Deviated septum. This is a controversial one. But
why?
Well, I know you don't like septum surgeries, but some people do have trauma, and this one was like a kind of a bad trauma, and it healed. And once the bone heals, he might have been okay with, palate expansion, or in an ideal world, a lot of people would get palate expansion, and then if they still need a septoplasty, they do it after. But some people, trauma or whatever, they do end up needing the septum fixed.
So in a case like this, do you straighten the septum, or do you just shave off the side that's projecting out in one way, or how do you fix that?
Yeah. Oh, shoot. I should have put a little graphic on that one. Here, let's see what I have. Because you make a little incision near the front on one side of the septum, and then you can get to the whole septum, and you take out a little portion that's deviated of the cartilage, and then put the cover. It's kind of like a sandwich. The bread is the lining, the mucosa, and then the cartilage is in the middle. So you can leave the lining, which is the important part. That has the nerves. That's how you feel the airflow. You just take out the deviated bone or cartilage. Because really, I have seen people, even after expansion, this doesn't straighten because you're a grown person and it fuses.
What even is the septum? What is the septum? Is it supposed to be like a chassis for the nose where it separates one side from the other as like a rigid kind of wall almost?
It's a wall. It's a wall in the middle that separates the right side from the left, but it's also support for your nose. It's the support. Um, I saw on Botched one time that a dentist did a septoplasty, and this poor girl, her nose fell. You know, if you don't have a septum, your nose will collapse.
Oh no.
So I mean, a good ENT will not do that to you. You leave the structural part. You only take the deviated part.
Mm-hmm. Mm-hmm. Cool.
So, but that's important. It's important for you to be able to feel the airflow. But you really can't just shave off one side, or you wouldn't feel the airflow. The mucosa is king. You have to preserve the mucosa for sensation and to feel the airflow.
Mm-hmm.
And then, okay, turbinates. You ready?
Sure.
So, I personally don't like reducing turbinates, but I will say, it's come a long way than it used to be. The people that have empty nose, I've only seen, I think, 2 patients my whole career, and I've done hundreds of septoplasties and turbinate reductions, like probably high hundreds. And the only empty nose I've had has been not my patients, thank God. But it happened a lot when ENTs used to cut out turbinates or just not care about the mucosa, But now any turbinate reduction is under the surface. So you preserve the lining, you preserve the nerves, and you preserve the airflow.
Mm-hmm. So what do you do? Do you hit it with the cauterizing tool, the IR?
I don't like that. I think that does cause some nerve damage, at least. It's called a submucous resection of the turbinates, which I think is what a lot of ENTs do, unless you get it done in the office, which I don't like. But you basically make a tiny cut here, and then you can kind of remove, not the bone, this is bone here, but
Mm-hmm.
some of this tissue that may be hypertrophic. But really, and this is what I always tell my patients, we have to figure out why your turbinates are swollen, because they don't just swell because they feel like it. If you're mouth breathing, even if I have the happiest patient in the world and they can breathe through their nose after a septoplasty, if they mouth breathe, the turbinate's going to swell again.
Mm-hmm.
So you have to mouth taping, whatever you have to do to get myofunctional therapy, to get breathing through the nose, that's going to keep the turbinates small.
Why does mouth breathing cause the turbinates to become enlarged?
We think there's a negative pressure system. I was trying to find the graphic. I couldn't find it. But just from the way air flows differently through the mouth compared to through the nose, the flow through the nose keeps them decongested. Mm-hmm. And we think there's a negative pressure system in the back of the nasopharynx that acts like a suction almost to create enlargement. Does that make sense?
Yeah, you mean it's almost like if you put anything in a vacuum, it kind of swells?
Yes, yeah. So if you're breathing through your mouth and you're creating this suction on the back end, this swells. But if you're, for some of this we don't fully understand, but we know that the nose likes to feel airflow. And if that's moving properly with Bernoulli's principle and, the movement of air, then it keeps them decongested.
Mm-hmm. Mm-hmm.
But, allergies can make them swell. Stuff in the air can make them swell. Sinus rinse helps to take all of that away and keep them from swelling so much. Mm-hmm. But if you don't address those, these problems, these causes, there's no point in doing this surgery, because then you have all the risk and none of the benefit.
Yeah. What do you think about pets? Just throwing this out there while we're on the subject of allergies.
It's okay. I love pets, but if you're not allergic to them, then it doesn't matter. It's a non-issue. If you're allergic to them, if you can keep them out of your bed at night, like without a cat sleeping on your face, then it gives the immune system a fighting chance to not be inflamed 24/7. And you have a chance. Otherwise, if you can't do that and you just have so much exposure, just do a sinus rinse. Just, your saltwater sinus rinse and rinse all that out, so it's not just sitting in your sinuses making you swollen.
Mm-hmm. Yeah. So do you think, is it a stretch to say that kids that grow up with cats in the house, let's say, Are they already at a nasal breathing disadvantage just in virtue of living with all that dander?
The data doesn't support that. The data actually shows if you have exposure during childhood, you're less likely to have an allergy to a cat or a dog because you've been exposed.
So it's actually like the people that get cats in their 20s and 30s, all the single
Mhm.
millennials that don't get married, that just get cats.
Yeah.
They're, they're
Maybe. They then they're not breathing and they only have a cat.
yeah.
That's a problem.
It makes me think of like the creepy Catwoman memes of like, lonely women that don't have babies and just get cats instead. The airway dimension is another thing that's kind of memeable about that, you
Mhm.
know.
Yeah, yeah. It's not helping.
No.
Or, I have a lot of patients that have mold. They find out they have mold in their house, so some kind of environmental exposure
Yep.
can cause your turbinates to swell.
No doubt. No
Then you
doubt.
can't breathe. Um, okay, so a little bit about this. This is actually a patient I had that had an old surgery. So you see the difference. I hope you can see the difference.
Oh, the
There's
turbinate's gone.
there's nothing there. And her septum, look,
Wow.
she's supposed to have a septum here.
Oh, wow.
Everything's gone.
That's barbaric.
Yeah, so it's different. It's different now. Um,
Wow.
yeah, and
Oh
these are
my
the only
gosh.
patients, out of all the septoplasties I've done, I haven't had anyone, but these are the ones, it's the ones I had another patient that snorted a lot of drugs and her septum fell apart like this, and she had empty nose syndrome. And
So
it's
that's true?
tragic.
It's true what they say that cocaine will cause a septum, like a
Mhm.
deviated septum?
And we don't know. Well, it causes she had a giant hole in her septum. It just ate through the cartilage, everything. Everything was gone, and her nose collapsed. So she could not feel herself breathing, and it was awful. She was miserable. But that's a really hard, almost impossible problem to fix once everything's gone.
You can't graft tissue back into the nose, mucosal tissue?
You can, but there's nothing to graft to. In her case,
Oh,
there was really nothing. You need blood flow, you need a source of so it can live. And it
wow.
was so gone. So I mean, there are things that you can do to fix it. And an empty nose now, we know now that there are things that we can do to help it. There's PRP, there's been some data on other injections that you can do. But these old surgeries, there's not a whole lot you can do because there's nothing in there.
Right. So would you even call that a sinus, or is that just a giant nasal cavity?
It's a mega sinus. It's yeah.
Does it make NO2? Or not NO, sorry, NO?
That's a good question. I don't know because she does have a little bit of thickening, so she has some chronic sinus disease. So I'd say this side is a little bit dysfunctional, but this side's probably working okay.
That side looks great.
This side looks normal. Oh, okay. So I have a public service announcement on my next slide. And I think this is probably pretty relevant to your viewers that I have patients that they can't breathe through their nose. And before they get to see me, they're using these sprays. And this
Mhm.
is terrible because they're so addictive. Do you know about this?
I do, yeah, like, are these steroidal sprays?
No, steroids are fine, but these are decongestants, Afrin. So
Tell us about them and why they're so bad and addictive.
yeah, what I mean, it's addictive because it's great. A steroid takes 6 to 8 weeks to work, but this will work immediately. You'll spray this in your nose, you'll feel like you can breathe great, and then you'll do it you're supposed to do it twice a day for 3 days and then stop. No more than 3 days. I have patients. I had one 17-year-old guy that was doing it every 20 minutes and he could not get off of it. He was so miserable. He would get depressed if he tried to stop. So, I mean, this is something really important to be aware of because it doesn't tell you on the box. Like, I can't even find where it says 3 days max because they want to sell it, right?
Yeah, they're drug dealers. They want you hooked on their drugs.
They're going to sell more if you take it every 20 minutes, but you'll be so miserable. And I have some patients that cry in my office when I tell them they have to get rid of this, or there's nothing I can do to help them because I can't make their turbinate hypertrophy go away if they're taking these.
How do these work, and what's the mechanism of the addiction?
They're decongestants. They're vasoconstrictors. So the opposite of nitric oxide. or yeah, they constrict the blood vessels, which is how they help you breathe. They make they'll constrict the tissue too. They make it smaller, so more air comes through, but then it wears off. It lasts 12 hours, it wears off, you got to do it again. And so people just never stop. They just keep going because they don't like how it feels when it wears off.
And so after you vasoconstrict them often enough, then they mega vasodilate because the body kind of finds a new homeostasis with, expecting the drug to come.
Oh, you're so smart. Yes. So you adapt. Your body wants to find a new baseline. So it's trying to overcome your vasoconstriction, and it's way worse once it wears off. So the first time you take it, it wears off, you're a little uncomfortable, you spray it again. Next time it wears off, you're more uncomfortable, you spray it again. And it continues happening because you get rebound that's even worse than what you started with.
Right. It's funny you say rebound because actually migraine rebound headaches work the exact same way. Triptans, which are like the primary migraine drug, are vasoconstrictors. They just kind of shrink everything up, cause everything to relax at the back of your neck and in your head. But if you take too many of them, now your body starts to like mega vasodilate, and without the drug, you just feel throbby all the time.
Exactly. Same. Yeah. Works pretty much the same way. So I think a lot of people probably don't know about this, and they're just using it and, oh, this is the only thing that works for me. Why won't anyone help me? And really they just need to stop. I've had to put people on steroids to get them off of this because they're so miserable. But whatever you can do to get off of these, and they come in all shapes and sizes. But
what do you think about xylitol spray?
That's okay. It hasn't shown to be addictive. Yeah.
Does it actually do anything though?
I don't know. The data's a little mixed because most of the data I've seen was from the company. So
yeah,
I don't know. I think as long as you're washing out, I have my patients use saline. Sometimes I'll put a little steroid in there if they have polyps. But it's really the mechanical clearance that's the most helpful.
What machine do you have them use?
Whatever they want. The squeeze bottle.
Yeah.
The only one I don't like is the pot. The pot is too passive. It won't get into the frontal sinuses.
Right.
Or the sphenoid. So you're missing half your sinuses.
Yeah. The pot is also hard to use, and you have to lean in a funny way. And I think people are drawn to it because it's like yogic.
Right. It seems natural.
Cool. Yeah, exactly.
Yeah.
I like the NeilMed sinus rinse bottles.
I like that one. I love SinuCleanse because it has a filter.
Ooh.
So there's one that, because I like to have an efficient system, so I can use tap water with the filter.
Oh, I love that because
Way
they
faster.
they tell you can't use tap water with the sinus rinse because of like some bacteria that like there's a 0.001 chance you'll get it, but it'll like kill you if you get it.
Yeah, it's not worth it.
Is that real? Is that real, by the way?
No, yeah.
Fuck.
And it's not, sorry, it's not worth the risk. We had a case in Seattle. I think it was 3 years ago. Somebody was using tap water. Seattle, they have purified water systems, but she died.
Is bottled water okay?
It should be.
Okay.
Yeah.
Fucking tap water, man.
I mean, if you have like some kind of filter, that should be okay, or a reverse osmosis filter. But distilled water is a hassle. Distilled water is the safest. It's a hassle. So yeah, the SinuCleanse filter, you can use tap water and it's safe. Yeah. So that's the end of my presentation. But was there a question that I was going to answer that I didn't answer at the end?
We were going to talk about minimally invasive turbinate reduction. And how and what that looks like to you. How do you reduce turbinates without causing ENS? Is turbinate reduction the primary culprit for ENS? Like, does sinus tissue removal ever cause ENS, or is that just too far back or up and around?
No, it's only been documented in turbinate reduction. Although there are some new things on the market that in my mind, I kind of wonder if those might cause it too, but we don't know. We don't have data on these new things. And I always kind of wait when something new comes out. I always kind of wait a little while before we start using it. Because some of the radio frequency ones, they're supposed to be easy. You can do them in the office, but we just don't know what they're doing to the nerves. So technically that's minimally invasive. Those those radio frequency wands that you can burn the whole turbinate with. But I don't like them because I don't think we have enough data on them to really know how they're affecting the nerve and your risk of
Right.
empty nose.
Right.
But I think the most documented way to do a turbinate reduction is the submucous resection, and you use it's a shaver. It's a microdebrider. You make a tiny stab in the front, and then you can take out a little bit of tissue under the surface, but you leave the mucosa, which is the important part. That's the part you need to feel the air.
Mm-hmm. So preserving the surface layer of tissue around the turbinate. And again, the turbinate is a bone that has soft tissue built off of it, right?
And then mucosa. Mucosa is like your cheek, the lining of your cheek.
Okay.
So it has that's the important part over the top of it.
Mm-hmm. So if you can get in beneath the mucosa and then remove soft tissue, that's how you do a turbinate reduction without causing ENS.
Yep.
Mm-hmm.
Yeah.
Wow. And how often are you saying to patients, you know what, I could do a turbinate reduction for you, but I really think you should go see this orthodontist first?
Yeah, I say it all the time, or I talk people out of turbinate reduction because I think with imaging, with some of the dental imaging, the turbinates get blamed for a lot of things because they look gray and they look big. Even a normal turbinate will look big on an X-ray. But I do talk people down off of that a lot because if you can fix something else and get to the root of the problem, it's better. But the problem is we don't have a lot of people to send to. So it's not an option for everyone.
Yeah, no, for sure. And interestingly, orthodontists have the same problem on the jaw surgery side. Very often, orthodontists are not sending patients for jaw surgery, even though it's what's called for, because they don't have trust in their jaw surgery partnership that they can send someone off to have that major procedure done without it getting totally screwed up and the patient coming back to them saying, what the hell did you send me off there for?
Yeah.
So,
yeah.
I get it.
Or if you find someone and you send it and they can't afford it, or it's, completely 5 hours away. I mean, it's hopefully people like you are changing so that we're changing the environment so that patients ask for it more and more orthodontists and oral surgeons start doing it. Because I think that would be best case scenario.
Yeah. Speaking of changing the landscape, I'm going to take this moment to pitch my ebook that's being published. It's on Substack. There's a link in the description below of this video. So I've been YouTubing and blogging for 6 years now. However, I never took all of my ideas and put them into one unified body of work. And I finally did. It's called Fix Your Face, the ultimate guide to mewing, expanders, and jaw surgery. There is a chapter on soft tissue nasal surgeries. A lot of the input that I'm getting from this interview will feed into that book. But I'm actually slow releasing the book on Substack in the form of weekly posts. So anyone interested in just kind of shortcutting the process of scanning through my videos that go back years, there's actually over 400 of them, and just wants to sort of see the core ideas presented in a neat, organized way, should go to the link in the description to my Substack and subscribe to get access to those ebook posts.
That's exciting. Congrats.
Yeah, thank you. So another thing I wanted to ask you on turbinates, have you ever seen a patient that had enlarged turbinates and they were a mouth breather, but they had pretty decent structure, and you were like, hey, you know what, Bobby, why don't you see a myofunctional therapist or practice nasal breathing? Maybe you don't need to see the myofunctional therapist. Just start breathing through your nose more, buddy. And then they do, and they're very proactive and very motivated. And then they come back to you 3 or 6 months later and their turbinates look better. And just as a side question, is there anything a person can naturally do to reduce swollen turbinates?
Yeah, no, that's a good question because that happens not infrequently. I'll have patients maybe a couple times a month that just come for that. They don't have anything. They think they have a deviated septum or they think, they have something, but they don't. It's just the turbinates. I'd say most of the time, almost all of the time, if I give them mouth taping or myofunctional therapy or sinus rinse, they'll come back and it's better. Or even, Flonase. Flonase is pretty safe. There's not a lot of, unless you have glaucoma, there's not a lot of downside to Flonase.
Mm-hmm.
So
What is
you
Flonase?
can
How
do
does it
that
work?
forever. And I say Flonase, but it could be any nasal steroid, Nasacort, Rhinocort. It will shrink. Some people, if they have allergies and say they don't feel like getting allergy shots every week, that's okay. If you do your one squirt twice a day in your nose, it's a steroid, but it doesn't get absorbed throughout your body. It's
Right.
less than 0.06% absorbed. So you're not going to get roid rage. But it will shrink your turbinates.
Did you say roid rage?
Yeah.
I think a lot of my viewers would want a little bit of roid
Maybe
rage.
more for them,
Yeah.
Extra Flonase.
Roid rage supposedly feels pretty good. I used to know a guy who he did steroids not necessarily to get bigger, but just because he felt amazing on
He
them.
likes it.
Yeah, he liked it.
That's like my
He liked it.
patients with thyroid hormones. They love it. They feel great.
Oh, I don't know anything about that. What's the story with that?
If I take out a thyroid, I put them on thyroid medicine. And a lot of times it's more reliable than what they were living with. They love it.
Shit.
They have more energy. They lose weight. They feel great.
Oh, yeah, man. Drugs, the cause and solution to all of your problems.
That's right. It's true. But yeah, Flonase is a good option for a lot of people. So it's a good starting point, or just, making sure the nose is clear and you're actually using it. Because I think a lot of people don't realize they're mouth breathing. And you probably know.
Can you cure or stabilize, beat back sinusitis with nasal rinsing and Flonase?
Sometimes if it depends on the sinusitis. If you're the type of person that just gets a few a year, then yeah, a lot of times you can make them less frequent so they don't last as long and they're not as severe just with sinus rinse.
So when you spray the bottle into your nose and it comes up one nostril and out the other, is it actually going into the side rooms and flushing a little bit?
That's what you want. So I'll tell you this because you have a lot of male viewers, if you squeeze it really, really hard and you want to think that it's going to be better, it's not better, because then it'll just go straight back to the back of the nose and miss the rooms.
Wow.
If you
Great advice.
do a gentle squeeze, like one side, half the bottle, just go back and forth till the whole bottle's empty. Then it goes in all the rooms. And we know because we've done studies on the flow of the rinse. But you have to wash that lining because it's designed to hold on to pollen and dirt and dust.
Do you think ancient man would clean out his sinuses in some primitive way back in the day? Was that
swimming.
Wow, you just blew my mind. You're just blowing my mind on this
it's
interview.
All saltwater.
Really? So swimming does that?
Yeah, it's great.
But interestingly, when you swim in a chlorinated pool, can it have the opposite effect because chlorine can be an irritant and an allergen?
Well, chlorine, it's funny. I was just reading a study the other day that chlorine can cure certain MRSA infections. So it's good for some things, but it does disrupt the natural, you want some normal bacteria in there. Right. And so chlorine will disrupt that.
Huh. This is such an interesting thought that perhaps a big reason why modern man is afflicted with this stuff. I mean, there's so many reasons, right? Breastfeeding, soft food, bad diet.
Our diet, yep.
Yeah, you name it. But also a lack of being in nature and swimming.
I think so. Yeah.
And this could be another reason why people on the coasts are just happier and healthier and more beautiful.
Maybe.
Right?
Yeah. They seem so relaxed. They have great sinuses.
They're breathing well. Yep.
Yeah.
Curveball question for you.
Uh-oh.
Can MMA jaw surgery, Bimax, actually make the basal bone of the nose bigger and improve nasal breathing? Or is there no anatomical basis for that?
I thought you were going to ask me if it could drop, because there was a study where they lost support to the nose and it collapsed from expansion this way. But you're talking about expansion MMA? MMA
surgery. Lefort 1 and BSSO, counterclockwise rotating the jaws and bringing them forward, a centimeter. Does that make your internasal passages bigger in virtue of relocating the maxilla?
Maybe a little from the maxilla. But I think the majority of the benefit is the the part that we have a hard time treating for sleep apnea patients is the base of tongue, because you get better suspension of the hyoid and all those muscles in the back of the throat. That's where it is. Maybe a little bit in the nose, but I don't think that's the majority of your benefit.
Okay. So in Dr. Tiau's perfect treatment plan, you include a maxillary expander even before jaw surgery as a way of getting optimal nasal breathing. You agree with the normal chronology
Mm-hmm.
sequence of events of doing the expander first and then the jaw surgery after.
Yeah, yeah.
Okay.
So that's going to give you your nasal breathing.
Do
Mm-hmm.
you have an opinion as to which MARPI expander is optimal for nasal breathing? This is kind of a super big question on my channel. Do you like the MSE because it's posteriorly placed? Do you like the custom MARPIs from the Partners Dental Studio? Do you like Casey Lee's Ease? Are you familiar with FME, which is like a big badass expander that's also posterior that is supposed to really deeply expand the nasal cavity by being set really far back? Or are you like not nerd level 25 on this stuff the way I am?
No, I wish I had the luxury of knowing all these things. I really have no one here doing it, So I just have Yousefian and whatever he uses.
Yeah, you're good. You
Hopefully
can,
it works.
oh, yeah, you can trust that whatever he does his own thing. He actually makes his own proprietary devices.
Yeah, and he uses,
So,
I think, yeah, 6 screws. But even he says, everything has a failure point and it depends on the integrity of the bone. So I think everyone can
yeah.
agree that tooth-borne is bad.
Believe
But
it or not, not everyone agrees on that. I certainly agree with you on that.
yeah.
But there's still a lot of normies in the space that think, oh, my epigenetic expander. They think that the tooth-borne expander is somehow not a tooth-borne expander and that it's changing bone structure. James Nestor is partly to blame because he cites in his book,
Mhm.
um, Breathe or Breath, I never know which one it is, that, he has this documented change in his bone structure from his I think it's a homeo block, whatever it was. So,
But I don't
yeah.
think he's documented the suture expanding.
Of course, the suture's not expanding.
So, yeah.
I always say, like, if an 8 tad MARPI struggles to split the suture after a piezo surgical assist, then a appliance that's pushing on your teeth is
On the
not going to
teeth.
split the
The
suture in an
teeth are the
adult.
point of least resistance.
It's that simple.
Yeah.
Yeah, it's that simple. Okay, so jaw surgery is not a dramatic improvement of nasal breathing in terms of
Mhm.
MMA. Paul Kochianchich said that on my channel when I interviewed him. I was because he said he doesn't like maxillary expanders. He's a jaw surgeon, by the way, in
Mhm.
Australia, a very well known orthodontic surgeon.
Mhm.
And he said, no, I don't like skeletal expanders. And I said, well, then how do you fix nasal breathing? And
Mhm.
he said, well, with jaw surgery. I said, really? That's interesting. But maybe the answer is somewhere in the middle there.
It might be, and I think we just need more studies of airflow, to be able to quantify, because you can estimate how much room you have from CAT scans, but we need better 3D mapping capability to know.
Hmm. Hmm.
But we think you don't get substantial improvement in the nose.
Hmm.
But the airway, yeah. I mean,
The pharyngeal airway.
mhm.
Yeah.
Yep.
All of the stuff starting from below the nose, the throat, um,
And
hyoid bone,
and
epiglottis.
maybe a little nasopharynx. Yeah, you
Mhm.
probably do in the back of the nose, just from stretch, just from putting a little tension on those muscles.
Right. Uh, is there a way of managing relapse after a soft tissue nasal surgery like a turbinate reduction? What's
Um,
what's the normal patient experience? Do they really almost always come back a few years later and being like, "Yep, I felt good for a year or two after the surgery, but now I'm
yeah,
stuffed
I
again."
agree. You mean if you just do turbinates? Because I have plenty of
Yeah.
patients that are years out from septoplasty, totally happy, love it, and I do septo and reduce the turbinates, and it's lasting if you breathe through your nose. It lasts years and years and years. Just turbinates, I don't know because I don't do that.
Sure.
I really don't. It's so rare. I've probably done like one just turbinate in my entire career.
Hmm.
So probably it would relapse if you don't find what's causing it.
Right. But you're saying though that nasal breathing is kind of like the management post surgery for keeping
Mhm.
everything chilled out and at its appropriate size.
That's your management. And I think that's the part we don't or we forget to talk about is, mouth taping. What if your muscles are too weak to hold your mouth closed while you're sleeping because you've always been mouth breathing? So we can fix it, but if we don't work on maintaining it, it's not going to last.
Mm-hmm. Mm-hmm. Doctor, I want to take this opportunity to ask you about my own nose, and I think it'll be informative to the audience too. And I'm not asking you to diagnose me. I just want you to look at these images and say uh, a surgical case or not a surgical case. Are you comfortable doing that?
hmm It's easier to look at you in person in your nose than an image, but we can look at the image
Okay.
and see.
I just want you to see my sinuses because the ENT that I saw was pretty insistent that I had um, uh, infected tissue in there that had to be surgically removed.
Oh, okay. Let's see.
But I kind of feel fine. But sometimes I get really bad infections. Like I get probably 2 colds a winter, and I'm wondering if this is the cause of why I'm getting 2 colds a winter. So black is space, right?
Mhm. And gray is bad. When you have symptoms, is it in between your eyes?
It's it's not necessarily. It's just I would say it's my right side more than my left, and for 2 or 3 times a year, I just get a really bad cold where I get a really nasty running nose that
hmm
lasts 3 days. I go through like 2 boxes of tissues.
hmm
I get a sore throat. I get nasty big snots that are green and yellow coming out of my nose for a couple days. Um, and I just get a stuffed nose during that period, especially on my right side.
And then do you end up needing antibiotics or not usually?
I never take them.
Okay,
I avoid antibiotics like the plague.
good.
But
That's great.
but but a couple years ago, it got to the point where I got an ear infection with my cold, and I felt like my ears were going to explode.
Mhm.
And actually, the ear infection was so bad that my hearing was messed up for a couple weeks after, where I was like listening to stuff on TV, and I was like, "That's not that person's
It's
voice. What's going on
echoey.
with me?" Yeah.
You probably had fluid in there. Your maxillaries looked good. They looked clear. You might have had a little bit of thickening in your ethmoids, but if really the way to know is if you had an antibiotic and then you take the scan. Because if you take a scan and you're sick, it's gonna look terrible.
Right.
But the question is, will it clear? Can we clear it? So let's see what you look like. Your septum looks good in the front,
Okay.
and your maxillaries are clear. Oh, it looks great. Let's see what he says. Yeah, a little bit of ethmoid thickening, but really not bad.
So this
And your
area,
turbinate, this is where your turbinates are gonna get blamed for everything, but
yeah. What do you mean? Why? What do you see there?
just because 'cause they're gray, but I mean, they look fine to me. There's a slight asymmetry, but your septum's beautiful. Look at your palate looks great.
It's big, huh?
Yeah, it's awesome. Yeah. No, I think your sinuses, I wouldn't do anything on those sinuses.
No.
Especially if the real way to know would be to make sure you're really healthy when you get the scan, because
I was healthy when I got this scan, by
you
the
you
way.
weren't sick.
No, I waited 6 months for the appointment, and then went in feeling normal. And then the reason I didn't do the surgery was because I felt fine at the time, and I just didn't wasn't motivated to do it. But then
Oh, here
I
it
got a
is. There's a little bit of lining. There's a little bit of thickening on the left side, but really, to me, I don't think that's
right here where his scroller is.
Yeah.
This sort of darker gray.
Yep.
That's the culprit tissue right there.
No, well, there's a tiny bit of thickening there, and there's a tiny bit in between your eyes that in the what we call the ethmoid sinuses. But the thickening doesn't go all the way around. So that makes me think that it might be a little bit of just reaction to your because do you have hardware in your
Hardware.
palate? What are
It,
these?
at this
What's the
time,
metal? Yeah.
yeah, I had lingual braces and TADs that the lingual braces were attached to try to mesialize my molars on my upper right side. This
Because
was,
I think that's
yeah,
just a reaction to the TAD.
really?
Hmm.
You mean in here, in the
Yep.
sinus?
Yeah. We see it all the time. Some people are actually, you're not allergic to metal, are you? Do you know?
Not as far as I know. Not particularly. Let's say that. Not particularly
Because even
allergic.
if you're not allergic, we do see turbinate hypertrophy from people that have braces that are allergic to nickel. That is the thing that happens. This can happen too. You can get thickening from a sensitivity to the metal, or just from the metal causing kind of a foreign body reaction in the lining of the sinus. But because it's only in the bottom, I wouldn't. I don't think you would benefit from surgery unless you were having symptoms all the time and you were miserable.
No, I'm not. And he even went as far as to say that one of my sinuses was completely blocked and unable to drain. Is that on the
Um,
right? Do you see that at
He
all in
might
your?
have been talking of your ethmoid. Maybe he meant one air cell, not the whole sinus, because it's really just a couple air cells in between your eyes have thickened lining.
Right.
But
Okay.
I wouldn't. Yeah, if I
So,
were you, I would hold off. I don't think that provides you a whole lot of benefit.
right. Yep. Huh. And that was kind of my impression. And by the way, this was, let me see the date of this video, 10 months ago. So this was last February or January, last
Mm-hmm.
January. I didn't do the surgery, but I've kind of been second guessing it and wondering if now that my, orthodontics is coming to a close, if I should avoid that. And another reason why I didn't do it was because I think at some point I might do double jaw surgery just because
Mm-hmm.
um, I'm still getting a lot of this in my sleep, like on occasion,
Mm-hmm.
and I maybe the jaw surgery will help with that.
Yeah, that and myofunctional therapy, which you probably, if you have metal in there, it's going to be hard for you to do that,
True,
right? But
true.
I'd be curious, once all this comes out, I'll bet a lot of that inflammation will calm down.
That's encouraging.
Yeah, I would wait. I would do what you're going to do anyway, and then wait and see how much calms down because, yeah, you need, the less is more. In your case, your sinuses look so good overall.
Thank you, thank you. I've heard some horror stories that people who do soft tissue nasal surgeries and then do a skeletal expander like an MSE or any kind of MARPE,
Mm-hmm.
or they do the soft tissue nasal surgery, then they do a jaw surgery, an MMA,
Mm-hmm.
that it can cause problems. Is that true? And if so, why does that happen?
I don't I don't know why that would be true. I don't think if you have a good like anything, right? It depends on who does your surgery. It depends how they do it and who does it. But I think most ENTs that do soft tissue, by soft tissue you mean a septoplasty.
Or sinus tissue removal, or
Oh, I don't.
yeah,
There's no way a sinus surgery because really you're just opening the openings that are already there. If anything, you're making them a little wider, but that's so far inside. It should be completely separate from any orthognathic surgery that you do.
would
The
it
only thing I could think that would be related would be the septum
septum,
if
right?
they don't leave you a good support. But really, nobody does that anymore. Most people leave good enough support that it can handle expansion.
You know what? Maybe that's what it is. It's when people get an over invasive
Mm-hmm.
septoplasty and then they're left with a paper thin thingy
Mm-hmm.
there, and then they disrupt the bone, and then that thing
Mm-hmm.
kind of maybe it collapses,
Yep.
or maybe bad things happen, right?
Because you need an L strut, and if you expand, if you take out the floor, if you don't have an L strut, you'll lose all your support. You'll lose your structural integrity. So that's
Mm-hmm.
probably, I'm guessing, what's happening. But if
Mm-hmm.
you check and make sure you're going to a board certified surgeon and asking questions, then it should be fine.
Yeah. I spoke to a patient last week who told me she had a rhinoplasty as a cosmetic enhancement
Mm-hmm.
and that it made her nasal breathing worse.
Mm-hmm.
Is that possible? And if so, what's the cause of that?
Yeah. So so different people do rhinoplasties. ENTs do rhinoplasties, but facial plastic surgeons do rhinoplasties, and we just have different approaches sometimes. Because I think ENTs are much more focused on breathing than I mean, we care about looks, but we care about breathing too. So some I have to be careful because I have a lot of friends who are plastic surgeons, and I think they do care about breathing. They just don't always look at it the same way that we do, you know? So,
I'm catching what you're pitching. So
so
then what do they do? How do they screw it up? Do they take out something that causes, I think she was saying that she's getting collapse
yeah,
now?
yeah. And actually I will say my friends who are facial plastics, they do put spreader grafts because if you, depending on where you fix the nose and the rhinoplasty, if you don't put cartilage in certain places, you will get collapse, and that's called the internal nasal valve. It's where the side comes to the septum on the inside. It's this little triangle. You can see it if you know someone who, when they, I have a little bit, when they breathe in, if it sucks in, that's nasal valve collapse. So
Is that Bernoulli?
yeah, that's what it is. If you don't put little spreader grafts in there, then you'll make the breathing worse. And it usually happens if they take down a hump and they don't put the grafts. Then you'll.
Speaking of humps, talk to me about whether you think that a lot of cosmetic nasal surgeries that are trying to make noses smaller are
Mhm,
really just coping for jaws being too small.
mhm,
Is it noses that are too big and hooked and humped?
mhm.
Are they really just small jaws that make
Yeah.
the nose look bigger?
Yeah, no, a lot of times that's what it is. And man, I just wonder how many times we could prevent that whole process if we kept people with, open, nice developed palates and kept them developing properly to begin with. You probably wouldn't see, because that graphic in the beginning, our friend Chad, you know,
Chad and Jeffrey, yeah.
yeah, if you none of that happens if you have a nice palate. It just, you wouldn't get that. And
Yeah.
that's theoretically why the hump happens to begin with, right? Because it doesn't have enough room and it gets pushed forward
Yeah.
and everything's rotated.
Right. Right. Do you do tongue tie stuff or not? Is that not
Mhm.
your forte?
I do. Yeah, I do a
You
lot
do?
of tongue ties.
Huh.
Yeah,
Do you do infant tongue tie
I do.
release?
Mhm. So that's where it's tricky, right? Because you can't do the full Zagi method on an infant. So
What
you
is the Zagi method? Enlighten us.
yeah,
Seriously.
it's really just and he probably describes it much better than I do, but um cold steel, so you don't cause a lot of coagulated, so you don't cause a lot of heat injury with lasers and cautery and things like that. Cold steel, get through all the muscles that are tethering the tongue, and then stitches. And I love stitches because it creates such a beautiful scar that's predictable. Because the problem is, if you just cut it, it's going to scar right back. You have two raw surface areas and it just scars back down. Looks like you never did it. So
Well,
that's the problem with
can it
babies.
sometimes heal worse
Um,
if it heals
maybe, yeah.
shorter without stitches?
Hmm. Yeah. So
So
the
you were
stitches
saying,
gives you a
yeah.
predictable. With babies, you kind of have to just cut it, and that has been shown. There's some beautiful studies of babies feeding and how they do before and after, and how much more effective it is. But really, it's the older ones that you can really address the muscles,
Hmm.
like those older kids. And the hope is that now you have that force that counters the buccal forces from pushing in. Now you have the tongue keeping the palate wide. That's the hope. Is it going to pan out? I don't know. It's a nice
Right.
dream.
So when Dr. Zagi talks about posterior tongue tie,
Hmm.
what does he mean by that?
Um, so there's all kinds of definitions, but I think most people mean, is it just the band of tissue that's the anterior part? Posterior is the tongue, the muscles in the back that are tethered. But I think everybody kind of wants the tongue to be up. We want the tip of the tongue, but also the back of the tongue to be up against the palate.
Hmm.
So
Hmm.
you release whatever you have to release to get it to sit where it needs to sit.
Right. Right. Yeah. Man, tongue tie is another thing that I really need to learn more about and get more content out on my channel. I should just have Dr. Zagi on potentially.
Mhm. Yeah,
Um,
he's nice. He's great.
so my daughter, I just had a daughter that was born 2 weeks ago.
Oh, congratulations.
Thank you. She's
She tongue
amazing.
tied?
Well, her tongue looks okay, but I
Mhm.
believe that she might have an upper lip tie.
Oh,
Um,
so that one,
what do you think about that?
I wouldn't worry as much about that one because the data, um, I will a lot of times release it if I'm there anyway. If I'm doing something else, sometimes I'll release it, just because there's some data that it causes that gap in the teeth and can cause gingival retraction, cause the gums to pull away over time. But a lot of
Can I
times
sh-
it self-corrects.
can I show you a picture of my daughter?
Yeah, please. How old is she? 2 weeks?
2 weeks.
Oh my gosh. And you're
But
awake and you look.
this is just going right to her tie.
Oh.
I don't know what you're seeing. Let me see
Is
what you're
she
seeing.
feeding okay?
Well, not she was initially, but now her upper lip is starting to peel off the latch.
Oh,
Can you
yeah.
can you
She is a little tethered. It's down low, isn't it? Near the edge of the gum.
here, let me get you a better. Yeah, it is. It's right down all the way down to the base of her
Oh.
maxilla.
So here's the problem. It really depends on the philosophy of who you go see, whether they're going to release it for you. I would probably do it if you're having trouble feeding, just because what's the risk, right?
Mhm.
If the baby's exhausted and mom's exhausted and it's way too much work, then it's worth a shot, because there's almost no downside to
Right.
fixing it.
Right.
But a lot of people say, well, no, it doesn't do anything. It's not, it's not necessary. It's not needed. But how do we know?
Right.
Really, there's not a lot of data. There's good data on tongue ties and breastfeeding for sure.
Here it is again.
Oh yeah, that's
See
a pretty
that?
good one.
That's a pretty good lip tie, right? Look, it's even
Mhm.
taking where her front teeth are going to be, and it's kind of
Causing a little notching. Yeah,
it's notching the maxilla area.
yeah. I would. I mean, if you
You
could
would,
find
yeah.
someone willing to do it for you, it's probably gonna. It very least it'll do nothing, but it has a chance of helping,
Yeah.
making it easier.
My poor baby.
Oh, she's beautiful.
Thank
She's
you.
so cute.
Thank you. Yeah, we love her.
Mhm. So, I mean, she'll cry for a second, but then they kind of forget. It's like it didn't happen.
How will they do it? Will they just take a scalpel and just cut up?
Usually it's a little scissor.
2 seconds, boom, in and out. Will they anesthetize?
No, usually we don't, because the risk of anesthesia is worse than the risk of, because babies can have allergic reactions even to that. So usually, sometimes you'll put a little pressure, to keep her from feeling it, and then just real quick, and
Yeah.
then feed right away so she forgets about it.
Yeah. I've got to find someone locally that can do that for her.
Yeah, a lot of dentists will actually do it, even on babies.
Is it hard to screw up a release like that? Is
Mhm.
that a lot easier than
Yeah.
a tongue tie
What
release?
honestly, what happens usually is kids rip it on the playground. That's usually how it goes away, is they fall and it gets ripped, and then
Can
it
my
goes
wife
away.
start working it with her finger?
It won't. You need something
No.
sharp.
Right.
Something sharp. I mean, there's data that if you do it lower down, it's better. It gives you better mobility. So there are different ways to do it, but it's kind of hard to mess up.
Yeah. You know what's really weird is breathing patterns in babies. Do you know anything about that?
Vaguely from med school, the babies have the faster, erratic breathing.
Yeah, sometimes they
They're
stop
so weird.
breathing for a little while.
Is she
And
full term?
yes, full term.
Yeah,
Yep.
yeah. Yeah, but even then, sometimes their just breathing system isn't developed. But then it comes. It gets normal.
Yeah. Do you work with lactation consultants and stuff
Oh,
like that?
yeah, yeah.
Do you believe that breastfeeding has a major impact on facial development in children
Mhm. And allergies.
and allergies?
Yeah, because that's
Do
your immunity, your first immunity. But yeah, I
do
think I think there's good data that things develop better. Your myofunctional. It's like our first myofunctional therapy, right? But it it's flawed if you are tongue tied. It doesn't
right.
work. You don't get as good of amplitude, and it's not as efficient.
Yeah. Yeah. One thing I've really been learning a lot about since my baby was born is the reality of breastfeeding and what that involves.
Oh, it's intense. Yeah, it's a
We do
lot of
not
work.
have It's a crazy amount of work.
A lot of work. Yeah,
And I don't think that we have a culture built for breastfeeding.
I agree. Yeah.
I think it takes a village. I think that if it's
Mhm.
just mom, dad, and the baby, if mom essentially becomes a cow
Yeah. Oh,
where
yeah, that's your job. That's all you do. Yeah. And but there's also no harm in, if you can't do it, you can't do it. I mean, I do feel like there's a lot of pressure to do it at all costs, but if, you're struggling and it's just not working, that's okay too. Baby just needs to eat.
what do you think about the balance between breastfeeding and supplementing? Do you think it's not,
Yeah.
because that's another thing I'm realizing is that it's not, is my baby breastfed or is my baby bottle fed? It's almost always going to be a mixture.
Yeah.
And what it's the better question is, how much is the baby breastfeeding? Is it 10 minutes a day, or is it a couple of feeds a day that are breastfeeding, or is it I always start her on the breast and then I finish with the bottle?
Well, and there are good bottles that have small flow, so the baby has to work a little bit harder at the bottle, and it mimics the natural process a little better. So it depends on the bottle. Um, and then, I mean, if you supplement with some good probiotics, that's helpful too.
Do you what bottle do you recommend, by the way?
We've always recommended Brown's, Dr. Brown's, but I honestly haven't looked at it in a while, so
Is
there
that
might
the
be some
lowest
better
flow?
things. They like a size one usually. The newborn nipple. You want low flow because you want them to work.
Yeah.
But
Yeah.
they have a good
Right.
one that's good for preventing reflux and helping with growth. But there might be better ones now too.
I've done some research and nothing really comes up as, advertising itself as a like a biomimicking human breast baby bottle. That
Um,
product does not exist.
we should make
But
that.
I've talked about I've actually believe it or not, I'm actually working on it.
Oh, that's great! Good for you.
Yeah.
I
Thank
love
you.
it.
Thank you. And it's not just a bottle. It's actually a wearable breast product.
Oh, what? That's
Yeah.
cool. Yeah,
That
because there are a lot of, it's kind of heartbreaking when moms give up and they're so hard on themselves. But what are you gonna do? It doesn't always work. So you can't
yeah.
just give yourself no grace in this whole process.
Women in our culture are just not raised with the mentality that they are going to become a sugar water supplier for this tiny little sugar water addict creature thing that it either is crying or it's eating, and the only way to make it stop crying is to feed it with your
Mhm.
breast. And that's just a huge paradigm shift
Mhm.
for most American women who work and who are
Yeah.
used to having their time and who don't have their mom and sisters and friends
Mhm.
around that they can pass the baby off to so that they can get a break and take a shower, go
Yeah,
exercise. When they say it takes a village, that's what they mean.
it's
I
true.
think
Yeah.
it really comes down to giving the breastfeeding mother a chance to
Mhm.
reclaim her sanity and do her
Mhm.
thing for an hour or two,
Mhm.
while the baby is being taken care of.
Yeah. Yeah, because you can't do it all alone. You'll go crazy.
Yeah. Yeah, exactly. And that's why I'm really motivated to get this product out, because I want dad to be able to wear something that warms up, that the baby can snuggle onto and uh,
That's awesome. And if you
feed
could
for 30 or
make
40
something
minutes.
palate friendly, oh man. Because I
W-
think a big part of this is, the thumb sucking, but the pacifiers and improper nipples creating that just pressure on the palate when it's so malleable in infancy is
you-
part of how we all got here.
Why doesn't the human nipple do that?
That's a good question. I don't know if it's something about the suction forces, because the human breast is pretty soft, but you actually have to, it takes more muscles than a, a bottle does. A bottle's easy. It doesn't take
Yeah.
as many muscles.
It's faster. I noticed that.
Mhm.
But in what it's about is like the baby will wake up in the middle of the night and it's like, oh fuck, well I just want to sleep. But then it's
Yeah.
like, well, the baby needs to eat before I can go back to sleep. So do I breastfeed the baby for 30 or 40 minutes, 20 minutes each side, or do I
Mhm.
just give them this bottle that
Mhm.
injects milk into them in 5 or 10 minutes, pacify the baby, quell the
Mhm.
baby's hunger, and then I go back to bed? The
Yeah.
whole thing is built off of speed and convenience.
And the baby learns it pretty quickly too, that they prefer that over the hard way.
And that causes them to become lazy on the nipple.
Hmm.
They don't want to work as hard.
Right. Yep.
Kind of like when, humans get used to eating softer foods and then you give them a steak, they're just like, this is tough. I don't want to eat this. You
Oh,
know,
yeah.
it's
No, but
kind of
that's
like
where
that.
the guy comes in too, is that there's a nipple that is connected to an computer software where we can measure how the baby's doing before and after the tongue tie, and it's so much more efficient. I mean, these are babies that stayed on breastfeeding for hours and got next to nothing, and then after tongue tie they can feed in 15 minutes, as opposed to this exhausting process. And mom wouldn't even know. How would she know that she's not feeding baby, because you can't see it?
Right. So how long should a breastfeeding session last?
Well, it varies, but I mean, it would be nice if it was 15. I mean, you can make it much more efficient if the baby can move the tongue, because
Right.
that movement and the deeper latch is what makes it more efficient. Because then you're using
Right.
all the
Right.
ducts instead of just, and less painful. Because that's why people give up too, because it hurts.
Because the baby ends up on the tip.
Right. Yep.
Yeah.
Yeah, and
Wow.
they're not working all the ducts, because there's a million ducts in there, and that's how you get infections. You're not clearing things out. It's a
Yeah.
whole deal.
Yeah, that's another thing that I learned since my wife started breastfeeding is that the milk doesn't come out in one spot, it comes out
Isn't
in
it
several
crazy?
spots. Is that what you mean by the ducts?
Yeah, yeah. There's a bunch of glands in there, and you got to clear them all, or they get stagnant and infected, and they hurt.
Right. Right. Wow. Maybe I really do need to get my baby checked out because if you think about the breast is like a reservoir and the baby is like the pump, and
Hmm.
if the pump is not strong and efficient, then it's going to take
Yep.
longer.
Because it's actually a complicated movement that the baby makes with the tongue and the palate and the cheeks to get all the glands cleared out. And
Yeah.
they just can't do it. If the tongue can't move fully up and down, it can't do it.
Right. Man,
So maybe, I mean, but you got to find somebody who can understand these things, because that's another thing that it's kind of in the beginning stages. We don't have a lot of data. So a lot of people, I hear pediatricians all the time, they're like, it's not a problem. We're not going to fix the tongue tie. But then there's studies like this that, why wouldn't you? If it helps the mom and the baby be successful, why wouldn't you? So.
yeah, yeah. Yeah, what do you think would be the most important features to include in like a breastfeeding mimicking product?
Oh man. Um, yeah, no, that's awesome what you've thought of, that it's wearable, it's warm, um,
It's really
easy
all
to
about the nipple though, isn't it? Easy to clean?
clean.
Yeah.
Yeah, yeah. Or like multiple pieces that you can like put some in the dishwasher and and change them.
Yeah.
But yeah, it's all about how it makes the baby's mouth without putting too much pressure on just the palate, too much upward pressure. Because you want side, that's what the breast does. It puts pressure evenly distributed because it's collapsible. It's very soft. So it puts pressure all throughout instead of just straight up. Like some of those hard nipples are just putting pressure on. You can see,
Oh, you mean the nipple is soft?
the if you take a bottle and you
Yeah.
put it in your mouth, you'll feel the resistance against the top of your mouth.
Right.
But
You're saying the human nipple.
oh yeah, yeah, the breast kind of squishes.
When you
Like
say the breast, you mean the
the
tip of the
human,
breast.
the whole breast, like the baby
Uh-huh.
will actually latch on a good part of the actual breast,
It
and
goes all the way around the areola. It goes
mhm,
deep.
deep,
The
yeah,
the
yeah,
if
and
the
it
if the
collapses. So the
Yeah,
pressure
yeah.
is distributed instead of just on the palate; it's all throughout the tongue and the cheeks and the mouth.
So you don't want this in the baby's mouth being pressed up onto the palate and onto where the front teeth are going to come in, because then you end up with that open bite thing that a lot of kids get, the
Yeah,
pacifier mouth.
and I do think it pushes your palate up, makes it high and narrow because you're putting so much pressure over time.
Damn, damn.
So no pressure, but if you could get on that, you'll change the world.
Yeah, I know. Maybe you should join the team.
I'd love to. That sounds great.
Yeah. It's going to be called the rack.
Oh, that's
Do you like
awesome.
that?
I love it. That's
It's either
awesome.
going to be the rack or the bosom.
No, the rack. That's
The
great. That's
rack, you like the rack?
great.
Cool, cool.
Yeah. If I can help, let me know. That's a great project. Noble.
Well, it definitely is going to need white coat endorsement, and it sounds like you understand the mechanics and stuff. So, no, seriously, maybe we'll talk more about that.
Yeah, that'd be great. Good
All
for you.
right. Well,
I like
yeah.
the
Thanks. Thanks. I'm thinking like maybe a $200 price point. I
Is it
I'd shit, I'd pay that.
Yeah, I think a lot of people would pay that
Yeah.
if it gave mom a break and a
And
chance.
gave baby a beautiful, healthy face.
Yeah.
You know, think of all the medical appointments you'll avoid in the future if your baby has a healthy airway, and all the
Mhm.
psychiatry appointments you'll avoid if the baby is beautiful and has good cognitive function from getting good sleep
Yep.
and
Oh
has
man, I
a,
have this conversation multiple times a day with patients. Yeah.
yeah. Wow. Wow. Oh,
Yeah.
there's
So
so
there's a
much work to be done.
huge market, but getting people to understand is half the battle, and that's what you're doing here. Showing people the the downstream effects that you're trying to prevent.
Yeah, I spoke to a guy the other day, this Stanford grad, and he was telling me he used like business terminology to explain it to me. He
Mhm,
said market awareness for this stuff is
mhm,
extremely low, which
mhm,
means that people don't even know that they have a problem that needs to
mhm.
be solved. So
Yeah.
it's hard to give people a product that solves a problem that they don't even know is a problem.
Right. But you could
So,
create demand. I mean, and depending on how you market it. I mean,
yeah.
even just as giving mom a break to
Hmm.
to go take a 10-minute shower.
Yeah. 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 Man. All right, doctor. Well, it's been an hour and a half. I want to respect your time. This has been very fun and very insightful. I've learned a lot,
Oh,
and
good.
yeah,
Me
and
too.
I, awesome,
Great.
and I think the audience is going to enjoy it. So, and I think maybe in a little while we come back and do another chat about some more baby questions, especially because I'm sort of dealing with that now.
Yeah, that'd be great.
And it sounds like you're. I didn't realize early in the interview that you were such a resource on infant stuff.
Oh, yeah.
But
I'm just fumbling through like everybody else. I mean, it comes to us as ENTs a lot, but there's a lot of work to be done, you know,
yeah,
to help people understand why it's important.
yeah, no doubt. Well, that's kind of where I come in on on a mass scale.
It's great. Yeah. Thank you for doing it. Good
Sure,
job.
sure. Thank you so much, doctor.
Yeah, it's been fun.
Okay, take care.
Okay.
Bye bye.